I'd like to thank everyone for taking time out of their busy schedule to join us. And this is the first of a series of initiatives that the Vascular Society will be having to try and take vascular care more out to the general practitioners, nurses, and allied health disciplines to try and bridge the gap between us as specialists and a lot of you who are out in the field seeing patients as the first port of call. We've tried to design the program such that it's applicable to the general practitioner to try and give you an approach to common disorders that you'll probably see in your daily practice. We've got a mixed bag of specialists, some a little bit older, some a little bit younger, who are there to share their experience with us. I'm going to ask Dr. Chopane to please start as the first speaker. He's a vascular surgeon who works in Nelspruit and in Raslo Private Hospital, and he's going to speak to us today on an approach to the leg ulcer. Over to Dr. Chopane. Thank you.
Good evening, everybody. Thank you, Riaz, for allowing me to present. And I don't know if my slides are visible. Yeah.
Yeah,
They are, you can
you
see.
can go ahead.
Okay. Just minimize this. Okay, so my topic today is essentially to just go on and speak on about approach to leg ulcers. And I think there's a very common condition, and most of the time, especially in the not so educated population, you find that we don't really get to assist or help or get hold of these patients. And actually, there's a lot that could be done, and there's a lot that needs to be known by them. So, uh, just going forward, a simple definition of a leg ulcer, it's by definition, it's a loss of an epidermis, which is extending into the dermis plus minus subcutaneous tissue, and it always depends on the extent of the damage or the disease. And it usually is something that fails to heal within 4 to 6 weeks. Usually earlier on, if it heals on, we consider just a simple wound. And often due to vascular disease or neuropathic inflammatory disease, not to a major extent, but it may also be uh, not to a major disease, condition, but also malignancy may be one of the causes. So one must note that leg ulcers are a clinical sign, not a diagnosis. And that's very important because diagnosing a patient with a leg ulcer means that we need to find out what might be causing the leg ulcer. So if you look at the epidemiological assessments and findings that you find, so lifetime risk about 1 to 2% of the population will be having this. However, one must note that in certain areas, that population might have slightly more than this. Elderly population, as you can see, the older you get, the more chances of you are getting this leg ulcers. And the biggest problem is the recurrence rate, which is actually quite significant, 30 to 70% of the time. And I think there's something one needs to discuss with patients most of the time to say, as much as we're doing something, the recurrence is quite high, but we need to work on it. And this is not a once-off journey. It's something that we're going to do over and over again. The distribution is quite variable. However, commonly we're dealing with venous, arterial, or mixed causes. And neuropathic, it may be addressing the remainder. However, there are other causes that would be causing leg ulcers, which I will mention later. So if you look at the most common cause, like about 90% of all the patients, the ulcer be either venous, arterial, or neuropathic. And then now if you look at other vascular causes that are non-arterial only, you can the mixed arterial, which includes most venous and arterial vasculitis, vasculopathy, calciophysiolaxis, and Begg's disease. But those are a few things. And one would say, I mean, if you're in the dermatology field, pyoderma gangrenosum, some malignancy and pressure ulcers, especially for those patients that spend time in the hospital. And considering I think with the COVID wave, a lot of people were put on to anticoagulants, warfarin. I did cause some of this ulcers as well. But there's one thing that one must know that Having an ulcer doesn't mean that have an ulcer elsewhere. It's just a simple let's sort out something. You actually need to go deep into the history, clinical exam, and discuss this. Now, common causes, the pathophysiology of it. So I think what is mainly we see the most is as much as depending on which segment, the venous ulcers. So it's essentially through venous capillary lead to very serious inflammation uh, and tissue hypoxia in that area, and with eventually leading to ulcer. When you're looking at arterial ulcers, it's essentially you reduced perfusion, ischemia, with eventuality of a necrosis. Neuropathic ulcer, loss of sensation, then sudden infection, but there will be all ulcers that that's important for one to know that. Um, there's a table, I think a lot of people probably taught me at the medical school, like, in chambers, but essentially just to say typical areas of at the venous house itself, essentially in the area which
Dr. Khopani,
depending to my
sorry to
depending on the
interrupt you.
y-
If you can just maybe
mhm.
put your video off, you have a bit of a problem with your bandwidth. If you can maybe switch your video off, thanks.
Is it better now?
We can hear you. It's a
Is
little
my
bit better.
is it
Yes.
okay? Sorry about it. So, venous ulcers typically occur in the medial malleolar region, the gaiter area. So there's always this. I think in most community, there's always this one person that has ever had this wound for years. And as a child, I was like, oh, what is this? This lady's always having a bandage and all. But only when I started growing and learning more, I realized, oh, they have venous ulcers, and that just goes to show that how long this can be troublesome to patients as well. And the edges are usually regular, sloping, with some granulation tissue, may be very exudative most times actually. And what's also a clear sign is that hyperpigmentation and associated eczema. More importantly, that pulses are present, and the edema is very common. And typically, the edema of this, it's a peating one. However, if it doesn't go to higher grades, like a phlebolymphedema, it may still be compressible or peating. And the higher you go with, or the longer it stays, the more difficult it is for you to assess the ulcer. And then arterial ulcers, usually toes, heels, lateral malleolar. This funny, well, not funny. They compared to the pain, to the venous pain, they really have severe pain, which may worsen on elevation. And more importantly, I think one of those things that we always say, no, patients will tell you, I have pain at night, and you ask yourself, why? Is there any condition that gives you pain at night? But I think it's all because of at night they're in a recumbent position. So that now just shows that now the gravity's power is all gone. And when now they walking during the day and all, the pain is a bit better, but they experience more of a claudication symptoms. And the edges are usually punched out, necrotic edges, shiny, there's no hair. And now the neuropathic pain, which I think most of us are actually not really familiar with this. Polypodiatric patients are seeing this a lot, and we are not really putting emphasis onto that. And they're often painless, and then there's usually a margin of callosity around it, and the granulation around it is usually dry and present in variable areas. And you can see other pictures that are depicted there. More importantly, this patients, if you think of it, if you have a neuropathic ulcer, there's probably an overlap of peripheral arterial disease as well, because some of these patients, depending on the underlying cause of the neuropathic ulcer, whether it's malnutrition from vitamin deficiency or it is diabetes. So one needs to really assess these patients. And more importantly, when you look at venous ulcer and neuropathic ulcers, there's usually pulses in the peripheral pulses. However, with arterial ulcers, they're usually reduced. And when you evaluate this patient, very important to go stepwise. History, very important. Examination, ulcer assessment, vascular assessment, neurological assessment, and investigation. And one must definitely identify red flags. And then you can establish the etiology. And this is not just, I'm going to examine somebody's leg or wound. This is a systemic evaluation that is very essential to make a diagnosis. As I said earlier, a leg ulcer, it's a leg ulcer, which is just, you need to know.
Dr. Kopane, I'm not sure if you can hear me. We seem to have lost you. Hopefully, you can rejoin us soon. We've lost some of your audio.
Underlying cause is there are no other confounding causes on this patient. And I think one of the things that you also take lightly, especially for patients with venous ulcers and for a bigger population as well. So also with pain, just to differentiate between the two, just mention severe pain, usually arterial or vasculitis, mild pain, usually venous. And venous is usually mainly in the late afternoon because that's when a lot of people are coming back from their daily routines and duties, and now they've strained a little bit. Neuropathic, usually not. And very important to ask whether they have rest pain, night pain, or worse on elevation, or better hanging down, because those are now danger signs for arterial pain. And that is it's equals to essentially rest pain. And then that would account it to being a CLTI until proven otherwise. And it's very important because then the management and the speed of care then changes completely once you've made an assessment of a chronic lymphatic ischemia. So I put it in a color coding just to look at history. Usually, what they might complain about leg swelling, heaviness, and varicose vein and skill discoloration when they present with venous problem. And that we usually find in females that had a couple of pregnancies, and sometimes even the family history. We do that, or patient with some intra-abdominal masses for a long time. That may have been the case, or patients that have been working in areas where the standing is one of those things that they do every day. And we're looking at arterial claudication, rest pain, and cold, and with a non-healing wound, those are a few things that one actually needs to elicit when taking history. And neuropathic pain, numbness, burning, loss of sensation, and if they've had previous ulcers. And you'd notice in most clinical practices, these patients, they don't really care for the wounds. They want somebody else to care for their wounds. It's a minority that really takes the initiative to really follow up and all. You have to call and ask them why didn't they do this. So it's very important, especially these neuropathic patients, because no pain. It means why do I need to go see a doctor until they figure out that they have to lose a leg? And that's when then they start being a bit more serious. If you look at various risk factors, I'll just start with first with neuropathic pains. So diabetes comes first, alcohol, and spinal disease. And spinal disease, one of the time, I think if you're not sure if whether it's arterial or not, just ask the patient how the pain is when they're climbing up the stairs. Because they go up, they close up, as they go down, they open up there. So they will probably differentiate between an arterial pain and non-arterial pain. So that will definitely tell. And if you remember, even the renal failure patients, they do have that malnutrition element to them, and it's very important for those dealing with renal failure patients to always be on the lookout for this, because there's usually an overlap between renal failure and diabetes, just compounding on the neuropathic risk factors. And the typical risk factors for arterial disease, being smoking, diabetes, hypertension, hyperlipidemia, and probably history of those that has been has been attacked by coronary artery disease or stroke. I did mention a bit on venous, like pregnancy, prolonged standing, and previous venous surgery. And with previous venous surgery is usually recurrence in your other accessory saphenous veins, or those that were not properly done or operated on earlier, that you might find that there is some recurrence on that. But most of the time, there is good information you get from the history. And I did mention some red flags earlier, but I didn't tell what red flags I'm talking about. So now, red flags are usually for an suspected atypical ulcer. So that will be an ulcer that has a rapid onset, or suddenly you have multiple ulcers. I mean, that would probably mean that you either have systemic disease, or you have to do other blood tests that would be, especially in a younger patient, exclude autoimmune disease or other causes that would not typically be between the three neurological, vascular, arterial, or venous. Or if the pain is very painful and worsening within the duration of the presentation, or patients present with systemic symptoms. And the systemic symptoms are not just isolated to, just pain. It can be other clinical symptoms related to other systems. Patients' immunosuppression, autoimmune disease, we've mentioned it a bit, and the malignancy history as well. Sepsis is very important because as much as it might be a small ulcer, if it is septic, that takes precedence, and the patient's sepsis control becomes a very important step for caring for them. And when examining these patients, you want to examine both legs from groin to foot, and you want to compare the site. And more importantly, you want to check the shoes. And don't forget to see how they walk, because it is very important to really assess them fully, because it's not just about what you see. Then the next step would be, who do I refer them to? Do I refer them to an orthotist? Do I refer them to just a podiatrist? And that's just a build up to say, we are helping you get this ulcer firstly away, but more importantly, to avoid also recurrence. So other few things that to look for, like, that would point towards a certain like edema, varicosity, lipodermatosclerosis, hair loss, and these are not, the only things. There's a lot of things that you have to look for. Unfortunately, for the presentation, you just can't put all of them. You just put the ones that we commonly see. And it's very important that we note that these are very important things to note every time you have an ulcer, to always look for. And when you're assessing a wound, it's almost like you need to tell a beautiful story. It's located at this specific area. This is the size. This is the depth. This is the edges. This is the base. And this is how much X-rays are coming from. And this is the order that is coming out, and the surrounding skin. Because now you have a starting point, you have your target. You want to assess that, but also when you're referring to the next doctor, they need to understand where we come from and where we're going, and the patient as well. You also want to see the outcomes as well, whether it being a wound sister, a podiatrist, a vascular surgeon, general surgeon, or whoever who may be dealing with wounds. So there's a few clues that would suggest on physical exams based on the locations I've mentioned as to where the ulcer is, like medial malleolar venous, toes arterial, heel probably pressure and arterial. And this, I think we've spoken a bit about. I'm just gonna go skip the slide. Just want to go to the next slide. So now the peri-wound examination is very important. So now patients with hyperpigmentation, lipodermatosclerosis, and edema, which is usually PT, will point most likely towards a venous cause. And now if you have a patient that has a shiny skin with hair loss and their limbs are cold, you probably think, yeah, I'm dealing with an arterial cause. Now, neuropathic is usually dry skin with some deformities. That's why I was saying, like, it's very important for you, because that some might have now flat foot for all, which is something new that they haven't noticed, and it would be something one needs to act on once that is picked up. The neurological exam, I think, I don't know how many people do perform this neurological exam, but I think it's very important because it does, exclude some of the small percentage of people that you may assist. However, one is a lot already. So the monofilament, 10-gram monofilament test, vibration, pinprick, temperature, proprioception, that goes to help you with assessing this patient before referring because you know where you're starting. And should you pick up that this patient has a form of a neuropathy, then you know the risk of an ulcer is. And then now the food care is different. It's not somebody that you just send home and say, no, it'll be fine. Then you probably need to refer to somebody that will routinely follow them and also feedback to the general practitioner that will be taking care of this patient for regular assessments and routine follow-ups to avoid now having to deal with ulcer. So when it gets to the vascular exam, it's very important to include all pulses, including capillary feel, temperature, color, and a Baker's test. Those are simple tests that you can do on the bedside. And there's always a question, oh, but then ABI, we can't do it. There's an ulcer around the leg. But then you can do toe pressures, and especially for those patients with diabetes, calcified vessels. And when you think you suspect your ABI is unreliable and your target, suspicious toe pressure will be anything that's less than 30 millimeters of mercury, not meaning that anything above that it's normal. So this would be now diagnostic numbers. And patients with severe ABIs that are low for severe ischemia would be one with a zero point 0.5 severe ABI, which will point towards severe ischemia. And Beger's test is a simple clinical test where elevation leads to leg pallor, and when you put it on dependent position, leads to rubor. And typically, you want to assess also the angle just to see, if somebody's leg turns pale at 2 degrees, then it clearly tells you there might be an extensive disease. However, if it's okay, still at 90 degrees, you might be dealing with somebody who has a fairly good supply to their limb. So in terms of an investigation, like I've just mentioned, you have just basics, ABI, duplex, and which is both arterial and venous, and you do based on your clinical finding and your clinical suspicion. In addition, that will be your toe pressure, TCPO2, CTA, and MRA, depending on what's available for you. However, everything here, these are not routine tests. These are tests that are done when needed and when you're working towards. And same to go with blood tests. They need to be tailored to the history of the patient and the physical exam findings because you can do a lot. And if they're not going to benefit the patient or they're not going to benefit the workup, it's actually a waste of resources. Just a few blood tests that one needs to do when assessing, but others, like I said, that we like your ANA, ANCA, rheumatoid factor cryoglobulins. There's a few things that you would do in a patient that you're suspecting atypical ulcers, or you're thinking that there might be an element of an autoimmune disease in those patients. So now, when doing this, requesting this Doppler investigations, you have venous, you have arterial. Duplex, venous duplex, we're usually looking at a few things. We want to look if whether there's a reflux, whether there's obstruction anywhere, whether the perforators, and the quality of the deep system. And in the quality of the deep system, we want to look at the patency, the reflux, same as the superficial system. And this is usually indicated for venous ulcer suspected, when you're planning to intervene, meaning that if you're thinking that you're not going to intervene in this patient, I think you would hold unless you're planning to have a follow-up basis where you see how this patient resolves. And the arterial investigations we've spoken about them, I would then go up and do the duplex and a CTA only when planning to intervene and in a severely symptomatic patients. But if not, I think some
Dr. Kopane, we seem to have lost you.
Yeah, it seems we've lost Dr. Kopane. He's pretty much finished the majority of his talk. I'm going to ask, in the interest of time, I'm going to
Uh,
ask us to move
uh,
on to Dr. Dokrat.
uh, am I audible?
Yeah, the time's pretty much up. We're going to move on to Mohammed Dokrat so we don't run over time for the entire meeting.
Okay. Not audible. Thank you. Thank you.
Thanks, Dr. Kopane. Dr. Dokrat is a vascular surgeon working out of Raslo Hospital. He works in association with Dr. Kopane, and we've asked him to speak to us today on foot disorders in diabetics. Over to you, Dr. Dokrat.
Hi, can you hear me and see my screen?
Yeah, please go ahead.
Yeah, good evening, everyone. I'm going to be talking on foot disorders in diabetes. It's a very large, substantial topic, so we won't be covering everything, but I think I got a lot of the pertinent points in, and I hope it's more of a practical presentation to help you to find and identify and treat these disorders. Okay, so why does it matter? I think Dr. Kopane has gone through it, but just out of interest, we can see that diabetes is very common, especially in South Africa when we look at the data, the number of adults in South Africa with diabetes is quite substantial. In 2024, we have around 2.3 million people with diabetes. That's not an inconsequential amount. And we know that picking up these disorders is very important because it helps us to recognize and change the outcomes of these patients going forward. What's the burden of disease? As I said, we're running well over 2 million. And it's around 7.2% of the adult population, which is quite scary. That's just under 10%. And it matters because the lifetime risk of you developing an ulcer or one of these diabetic foot-related complications is about 20 to 35%. If you have peripheral arterial disease, developing an ulcer is around 50%. So these are not inconsequential numbers. To understand the diabetic foot problem, it's important to just have a brief understanding of the pathophysiology. It all stems from that. Ulceration is not just a skin defect. You have to find out what is the driving factor behind it. And that's what encompasses diabetic foot disorders. And as you can see on the screen, there's two ways of looking at it. But in essence, the big components that we want to look at in this talk is definitely going to be the neuropathic pathway and the degeneration of the nerves, vasculopathy and the vascular complications, as well as infection. So what exactly counts as a foot disorder? So there's a lot of discrepancies between the terminologies, etc. So I've tried to list as much as I can here in this slide. And as you can see, there's too many really to go through individually and try and get the treatments for all of them. But it's important to understand that it encompasses a wide array of different conditions that you are going to potentially encounter when you get these diabetic patients. Specifically on peripheral neuropathy and foot deformity, the neurological pathway that goes on with diabetes is probably one of the most important pathways to understand. The degeneration of those nerves literally stem into all of the other conditions. And we know that diabetes affects all of the nerves. So from the sensory pathway, you're going to get loss of pain and pressure, and that's why these patients don't notice their trauma. You're going to get motor neuropathy, that dysfunction of the intrinsic muscles of their foot. So they get these foot deformities, higher arch hammer toes. You get this autonomic neuropathy, and this causes decreasing in sweat. This leads to opening and cracks in the skin, which all of these can later develop into an ulcer, into sepsis, and a variety of other conditions that we experience. Peripheral arterial disease is another very common pathway in which you develop these complications. It's present in around 50% of patients with diabetes. The symptoms, I think, are somewhat masked, especially in those with concomitant neuropathy. You'll find that a lot of the diabetic patients, they don't have very good sensation, and they won't actually tell you that they have claudication or rest pain or present like a typical peripheral arterial disease patients. It's important to also know that these patients also have the generalized disease of atherosclerosis. So they've had heart attacks, strokes, so their functional status in and of itself is quite low as it stands. An infection being really the last real pathway that you get these diabetic foot disorders. And that's a sort of generally an easier one to pick up. You find the signs of infection with erythema, induration, warmth, tenderness, pain, purulence. And it's important to try and classify how bad it is. Does it determine, are you going to refer this patient? What antibiotics you're going to give? What sort of referral pathways this patient is going to follow? And it's reasonable as a first choice to do a plain X-ray and inflammatory markers. But the most important point is when you identify somebody with infection, it's early antibiotics after you take a culture. In the red box at the bottom, think osteomyelitis. So this is probably the pinnacle of when you need to refer and transfer these patients. Osteomyelitis in these patients is relatively severe. It is a life-threatening condition at times, and it's normally something that's not going to be treated locally without admission. So it's important to just try and have an algorithm in your mind when you will be able to find which patients you think will have osteomyelitis. You'll see the slides are generally quite busy, and I'm not going through all of them. We will be sharing the slides, so I'm just mentioning some of the pertinent points, and at leisure, others can go through it if they want to. So a structured assessment in a diabetic patient, if you look at all of the texts, whether we look at our textbooks or various guidelines, we have this long drawn out history and examination and sort of bedside test that we need to complete in these patients, but that's often not something that we're going to be able to accomplish. So if you look at the blue box at the bottom, besides the history, on examination, the key things that you want to, which will take less than 5 minutes, is examine the pulses. That will give you your answer if the patient has a vasculopathy or not. Examine for neuropathy, which is a sensation examination. If you have a monofilament or a tuning fork, however your chosen method is, sensation is viable to examine. And then lastly, looking for the signs of sepsis would be the three most important things that you want to identify in these patients. I put this slide in here, you can go through it. And in essence, how the referral pathway should work is normally the more extreme conditions get referred to specialists. But in essence, a GP is going to see a lot more patients with diabetes. It's important to figure out when you should be seeing these patients. So I put in here 2 guidelines which sort of stratify patients, and you can go through it in your own leisure, but it's important not to identify the condition and then not follow up with these patients in the future. So just some basic principles when you're dealing with patients with these diabetic foot disorders. And I've highlighted some of the things that I think are important that myself included are guilty of not doing. One of the most important things is just telling your patients to have good foot care. Having some of these posters or pamphlets to hand out to patients, even if you don't have the time to explain to them, is of paramount importance. Patients can generally irk on some of the inspections and some of the healthcare of their feet. I think if you give them something and educate them and grant them knowledge, it makes it a lot easier that they'll be able to identify a lot of these problems very early on. One of the other treatment modalities that I think we're all guilty of is offloading and footwear. There's a whole host of different footwears that you can ask your patients to wear, and you can advise them on. But in essence, you want something that's airy with potentially gaps and spaces, nothing that has hard soles, pressure points. And then specifically when you're dealing with some of the complications and ulcers and wounds, you want offloading devices, which I very rarely see patients wear, but it's so important. You cannot expect any of the wounds or ulcers to heal while you're still putting continued pressure in that vicinity. This is just a little table on giving some practical points on which patients to refer. So you've identified that this is a patient with a diabetic foot problem, and when should you, in essence, refer? And it becomes sort of a practical judgment. Anybody with complications such as an ulcer with fever or sepsis, an ulcer with ischemia, if you're concerned the bone is involved, and any form of gangrene or tissue loss should come immediately. And within one working day, you're seeing the patient later on in the afternoon, is pretty much all the diabetic foot problems should be seen at some stage by a relevant specialist. It matters that they get seen at least once, because if you delay the tissue loss that will occur and the spreading of sepsis definitely gets accelerated in these diabetic patients. Who is part of that team? And you can see that there's a lot of components to managing somebody with diabetes. I think we get desensitized to who exactly needs to come through because we see so many patients with diabetes. I think it's important that your diabetic patient should have a GP or family physician that they're following through with continuously, that's getting this early detection through and optimizing their medical treatment. Prevention is so much better than cure. We all know that, and having that local institution that sees to you is of utmost importance. The diabetic team, whether it's a sister or a nurse or the local pharmacy that checks their glucose and grants them education, that's something we tend to lack in our local vicinities. And then we all know generally the referral pathways for orthopedics. It's going to be the Charcot's foot and the foot deformities, and then your orthotics department for offloading, vascular surgery for our various conditions. But it's also important we don't forget our allied services. So podiatry and foot care can take a lot of the burden away from a practice and help the patients with their calluses, their nail care, their footwear, and prevent a lot of these conditions from developing and progressing in the first place. Very briefly, this is just my own little practical algorithm that I sort of developed just to keep things as simple as possible. Patient comes with diabetes as a regular or routine follow-up or for any concern, removing the footwear and inspecting both the feet with some of those crucial key points that I've mentioned, then deciding if the foot is at risk or does it have an active foot problem that needs referral. If there is an active foot problem, the key points to note is there infection, ischemia, gangrene, deep sepsis, or Charcot's foot? All of those patients need to offload immediately, need to protect that foot, document, and start with the appropriate treatment, and referring, as I had stated before, for these patients. What is the take-home message? Is the diabetic foot is won or lost very early on. By the time the patient gets to a specialist in any discipline, chances are that foot is already very, very compromised. The GP's role is so crucial to recognize those dangers, start safe care, shorten the time to get to the right team. I know it was a lot of information that I presented on the platform. These slides will be shared, so if anybody's interested in reading further, but I tried to just give a quick overview on what is a very, very big topic. Thank you. And in the presentation as well, you'll see that there is a lot of references.
Thank you, Mohammed, for a very practical and talk on a very difficult and very large subject. I think you've done justice in the time that we've allocated to you. It's an oversight on my part. There is a Q&A box at the bottom. So if anybody has any questions that you want to pose to us, please feel free to type your question in the Q&A box, and one of the panelists will answer your question. At the end of the following talk, we may take a few live questions pertaining to the first 3 talks, and then we'll continue with the remainder of the program. So the next person to speak is myself. And I'm going to speak to you today on deep vein thrombosis. Let me just call my slides up very quickly. A moment. All right. So I've been asked to speak on deep vein thrombosis. Again, it's a huge topic, and I thought I would just go through some of the current perspectives on the diagnosis and management of the subject. So venous thromboembolism encompasses both deep vein thrombosis and pulmonary embolism. Deep vein thrombosis refers to the formation of thrombus within the deep venous system of the leg. And for the purposes of this talk, we'll not delve any further into pulmonary embolism. Deep vein thrombosis is a significant event. It occurs in more than 10 million patients per year, with more than 50% of cases related to either hospitalization and/or recent surgery. But what's really interesting to note is that the majority of patients will actually present post-discharge. So we as hospitalists may never actually see these patients. It's often the family physicians and the general practitioners who are the first port of call for these patients when they present with deep vein thrombosis. It's the 3rd leading cause of vascular death, and it's got significant, not just short-term mortality, but often long-term morbidity related to the development of the post-thrombotic syndrome. So if we have to consider what are the risk factors for the development of deep vein thrombosis, we can see that it increases with increasing age. Females, however, tend to have a greater risk when they're younger due to the use of estrogen-containing products, as well as pregnancy and the post-pregnancy period. Males, on the other hand, tend to have an increased risk with age and tend to have a much higher rate of recurrence. Interestingly, in up to a third of patients, you may never find a provoking or causative factor. We often utilize the causative factors to determine duration of therapy. When looking at the factors, we often like to divide them into persistent factors or transient factors, and transient factors are subdivided into major or minor. And if you have a look at the table, they're all clearly listed. The sort of inherited coagulopathies or coagulation disorders, we often over-test for them, and we'll discuss that a bit later. Some of the strongest acquired risk factors include malignancies, and so one of the sort of the strongest transient factors is related to surgery and admission to hospital, where interestingly enough, we tend to confine patients to their beds and increase their risk for deep vein thrombosis. So just looking at the classification, we often get reports on ultrasounds that say upper segment and lower segment DVTs. And this definition has subsequently or recently been changed. So the way to look at the venous system of the limb divided into 2 systems, the superficial system and the deep system. The deep system is divided into what we call proximal DVT and distal DVT. Your distal DVT essentially involves your calf veins, either your gastrocnemius or your soleal veins, or your anterior posterior tibial veins, or your peroneal vein. Everything proximal to that, your popliteal vein, your femoral vein, and your iliac veins would be referred to as a proximal deep vein thrombosis. We do subdivide the proximal segment into iliofemoral DVTs, which essentially are the common femoral vein, the external iliac vein, and common iliac vein, and the inferior vena cava. So if we move on to the clinical presentation, the difficulty with DVTs are the symptoms may be non-specific, and they've got a vast differential diagnosis, which may include cellulitis, lymphedema, superficial vein thrombosis, trauma, post-thrombotic syndrome, or even a ruptured Baker's cyst. Patients may often present with pain, some may present with swelling and tenderness, usually in the calf. Interestingly, certain patients with isolated calf vein DVT may be completely asymptomatic. Occasionally, you may see thigh swelling or lower back pain if there's more proximal iliac involvement. So how do we work out who do we investigate for a DVT? Because there's obviously a significant economic component to this as well. So we need to try and assess sort of the pre-test probability of, does this patient potentially have a DVT? And the Wells score is an excellent model to try and direct our decision making. So it's got a whole host of factors. You can read it on the screen, and it assigns a score to each one of them. And if you think an alternative diagnosis is as least likely or more likely than a DVT, then they get a negative score. There's two different models. There's the Wells scoring system, which uses anything -1, -2 to 1. It means the diagnosis is unlikely, or anything greater than 1, the diagnosis is likely. There's also a probability scoring system, but they've compared both. There's no difference between the two of them. So if we apply our Wells score to our patient, we will be assessing the pretest probability, and it's either going to be, we think that a DVT is likely if the score is greater than 1, or a DVT is unlikely. So if we go down the pathway first of DVT is unlikely, the next thing to do would be to get what's called a D-dimer done. So D-dimer is a blood test. It's a measurement of fibrin degradation products. So if you've got clot somewhere in your system, the clot is being broken down, and this is a measurement of the breakdown products of that. It's got excellent sensitivity, more than 95%, and excellent negative predictive value of almost 100%. The problem with the D-dimer is that false negative. So you can get false negative if patients got a calf vein DVT, patients on anticoagulants, as well as patients who present late. You may have a false negative. The biggest issue, though, is that it's got very poor specificity, and there's lots of false positives: infections, cancer, recent surgery, and pregnancy. So essentially, the D-dimer is an excellent test to exclude a DVT. So low probability, you've done a D-dimer, the D-dimer is negative, you've essentially excluded a DVT. So if we then move on to the patient who has either a positive D-dimer or has a DVT that's likely on our initial Wells assessment, the next stop would be to obtain a duplex ultrasound. And you can see this is a class 1 strong recommendation. So what's the role of an ultrasound? An ultrasound in venous disease is essentially the gold standard for diagnosis of a deep vein thrombosis. There are two techniques that have been described. The compression ultrasound, which essentially is a 2 or 3 point test, usually looking at the popliteal vein and the femoral vein in the groin. If you can compress the vein, there's no clot. If the vein is incompressible, usually there's clot present. A more detailed study is the whole leg ultrasound. This adds in color flow, and this allows us to assess for distal DVT as well. This is, however, a little bit more time-consuming and operator-dependent. If you've got an inconclusive ultrasound, you've got one of two options. You can choose to repeat the ultrasound again in 5 to 7 days, or you can proceed to do a CT venogram. I would, however, caution that CT venography is usually reserved for patients where we suspect iliocaval involvement, and we want to visualize the iliac and the iliac veins, which are not clearly seen on ultrasound. I've also put up on the slide some of the recommendations from the European Society, and you can see that they give it a class 1 recommendation for ultrasound as the first modality. So if we've got an ultrasound, we're going to see one of two things. If it's negative, we can choose to repeat it after 5 to 7 days. If there was some doubt or it's inconclusive, you can either choose to repeat the scan, or you can proceed to do a CT scan. If your ultrasound is positive, it's confirmatory that you've got a deep vein thrombosis. I want to stress that access to imaging sometimes is restricted or not available. And if you suspect that the patient's got a DVT or a pulmonary embolism, and there may be some delay, don't hesitate in initiating therapeutic anticoagulation. You don't need to confirm the diagnosis with an ultrasound to start anticoagulation. You can always start it, and if it's negative, then you can stop the anticoagulation. So in terms of treatment, anticoagulation remains the mainstay of VTE management. The primary goal is to prevent clot propagation with subsequent embolism, which may be fatal. We've all grown up, sort of the older school, start the patient on Clexane and then put the patient on a vitamin K antagonist such as warfarin, and we know the issues with that. More recently, it's now been clearly established that the direct oral anticoagulants, the DOACs, are now the standard of care, with low molecular weight heparin and vitamin K antagonists reserved for certain specific indications. And this allows the majority of patients to actually be managed on an outpatient basis. So this is just a table that goes through the sort of various anticoagulants that are available to us. And I thought I would just very briefly go through them. Vitamin K antagonist, it's warfarin, it's a fairly well-known drug. The difficulty is that the patient needs to be started on some form of parenteral anticoagulation, usually with a low molecular weight heparin. Patient needs to be transitioned across until the INR is therapeutic, and we all know that this takes usually a few days with lots of dose adjustments, the lots and lots of drug interactions. However, it is well validated, it's efficient, it works. In our setting, it's very cost effective. I looked at some costing, and warfarin for a month will set a patient back around 60 Rand. So a lot of the schemes will actually pay for this, and it's safe to use in patients who've got renal failure, and we've got well-established reversals. The low molecular weight agents, that one we typically use is Clexane. It's usually a twice daily subcutaneous injection. It does require some adjustment in patients who've got renal impairment. The problem is, it works really well, but costing, as well as the need for regular twice daily subcutaneous injections. A month supply of Clexane will set a patient back between 5,000 to 6,000 Rand. So it's not a very practical agent to use on a long-term basis. Fondaparinux, Erixtra, it's once daily dosing. Again, increasingly expensive, probably in excess of around 4,500 to 5,000 Rand for a month. We usually use it for patients who've got heparin-induced thrombocytopenia, and then this agent can be utilized. Just moving on to some of the more sort of the NOACs or the DOAC agents available in South Africa, we've got dabigatran, apixaban, and rivaroxaban. Dabigatran is a direct thrombin inhibitor. It's a twice daily dose of 150 milligrams. The downside is that patients need to be bridged with a low molecular weight heparin prior to initiating dabigatran. It doesn't require any drug monitoring, which is fantastic. However, it's predominantly excreted by the kidney, and in patients with renal failure or renal impairment, it cannot be used. Reversal is available in the country, but it's exceedingly expensive. It's about 50,000 Rand for reversal. The benefit of all these DOACs are they're relatively short acting, so sometimes withholding the drug or stopping the drug in a patient who's got a bleed is sufficient. Apixaban, it's commonly known as Eliquis. It's got a loading phase for the first week, 10 milligrams twice a day. Thereafter, you can switch to 5 milligrams twice a day. It's got a fairly good safety profile. It's recently been FDA approved for use in renal failure. There may be some need for dose adjustments to reduce it down, even down to 2.5 milligrams twice a day. Reversal is not available in the country at the moment. Rivaroxaban, commonly marketed as Ixarola as a generic, again requires a 15 milligrams a day for 3 weeks as a loading dose, followed by 20 milligrams once daily, not to be used in advanced or renal failure. Reversal is again not available in the country. Interestingly, apixaban, the costing is around 500 Rand a month for a 5 milligrams BD dose, and Xarelto, the generic, is around 400 Rand a month. So the prices have significantly come down to make them more accessible to our patient population. Just a very brief slide on the evidence. This was a meta-analysis. They looked at the seminal trials done on these novel agents and compared them to the vitamin K antagonist warfarin. And the findings were that they've got similar efficacy for the management of acute symptomatic VTE, but they do come with slightly lower risk for bleeding. So they're definitely the way to go. When deciding how long to treat patients for, we essentially have to look at the risk factors that we alluded to earlier. Patients who've got a major transient risk factor, someone who's post-surgery, they get 3 months of treatment with the DOAC, and then you would stop because their risk of recurrence is exceedingly low. The other category, patients who've got major persistent risk factors, patients who've got active cancers, antiphospholipid syndrome, or they've had more than one thromboembolic episode without an identified provoking factor, their risk is exceedingly high for recurrence, and one needs to continue them on long-term anticoagulation. It's the patients in between where there's clinical equipoise in terms of what is the correct approach, how long should you treat them for, and what dose of extended therapy should you use. And we'll try and just touch on some of that in a bit. So again, looking at some of the recommendations for the provoked DVT, in patients who've got a provoked proximal DVT where there's a risk factor that's persistent other than malignancy, there's a class 2A recommendation that anticoagulation should be extended beyond the 3-month period on condition that you evaluate the bleeding risk. In patients, again, who've got a provoked proximal DVT with a minor transient risk factor, again, one should look at their bleeding risk and then determine whether you should extend the anticoagulation for a longer period of time. This has gotten a class 2B, so slightly lower recommendation. In the unprovoked category, patients who've got unprovoked DVT and who are at low or moderate risk for bleeding, their anticoagulation should be extended beyond 3 months. Again, reassessing their risk for bleeding. They advocate the use of the DOACs over vitamin K antagonists. In patients who have got unprovoked DVTs and you're extending their beyond 6 months, and if you feel the risk for recurrence is not very high, then you can actually reduce the dose of the DOAC. So for apixaban, it was 5 milligrams twice a day. You could choose to reduce it to 2.5 milligrams twice a day, and rivaroxaban can be reduced to 10 milligrams once a day. There have been a whole host of meta-analyses that have recently been published that have shown excellent safety in terms of thromboembolic prevention with the smaller doses, with a significant reduction in bleeding. Just one note that aspirin should not be used as a form of antithrombotic therapy in an extended period. So just to touch on the assessment for bleeding risk, the incidence of bleeding is usually highest in the first sort of 3 to 6 months, usually around 2 to 3%. Thereafter, it's approximately 1% in your extended therapy group. And it's interesting that patients who have bleeding tend to have higher case fatality than recurrent VTE. So just to contextualize sometimes the significance of patients who undergo major bleeding. The aim is to identify and modify risk factors for bleeding. So frequent reassessment of your patients, look to see, do they still need to be on antiplatelets or non-steroidals? Is it feasible to stop them? Try and make sure that if they're hypertensive, you adequately control the hypertension, reduce the alcohol intake, and try and reduce their risk of falls, because patients who are anticoagulated with falls tend to have poor outcomes. I just wanted to then touch on just a few fairly common scenarios that you may encounter in your clinical practice. We know that patients with malignancies are at very high risk, one, for the development of deep vein thrombosis, but also for the development of recurrent VTE, as well as bleeding related to their malignancies, either from the tumor itself, from chemotherapy, from thrombocytopenia. So traditionally, low molecular weight heparin has been the preferred agent. However, more recent evidence suggests that the DOACs may be associated with better thromboembolic prevention, but with a slightly increased risk for bleeding. So just to qualify the statement a little bit further, the increased risk for bleeding was found predominantly in genitourinary or intraluminal GIT malignancies. So again, you can try and select out your patients in terms of what drug to put them on. Amongst the DOACs, apixaban seems to have the most favorable profile with regard to cancer-associated thrombus. It's got the lowest risk for recurrent DVT and also had a fairly good bleeding profile. Another important category to look at are women of childbearing age. And menorrhagia obviously is going to be a huge problem for patients or for females who are going to be put on anticoagulation. So I think it's important to obtain a proper history. Do they have pre-existing menorrhagia? In these group of patients, apixaban, dabigatran, or a low molecular weight heparin is preferable to a VKA. And interestingly, one should avoid abrupt cessation of the oral contraceptive pill on diagnosis of DVT. We've all been guilty of it. We find that the pill must be the offending agent. It's the first thing that we do is we stop it. And often what this can do is precipitate a withdrawal bleed that makes their menorrhagia worse. So the suggestion would be to place them on anticoagulation, keep them on their OCP, and then gradually switch the OCP from one that contains estrogen to one that's essentially progesterone containing, or to another method whilst the patient is on anticoagulation. In terms of pregnancy, there's no evidence for safety of the DOACs in pregnancy. There's an up to 30% increased risk for miscarriages reported with Xarelto, and there may be up to 5% risk for fetal, I apologize for my spelling, for fetal anomalies. So DOACs are clearly unsuitable for use in pregnancy. Similarly, warfarin or your VKAs, a high risk of teratogenicity beyond 6 weeks. So in this category of patients, low molecular weight heparin would be the way to go. So just to touch on the antiphospholipid antibody syndrome, this is an acquired autoimmune disorder. It's responsible for arterial venous thrombotic events as well as recurrent pregnancy loss and morbidity. It relates to beta-2 glycoprotein, the cardiolipin antibodies, and lupus anticoagulant. And you can have 1, 2, or all 3 of these positive. There's high risk for recurrent thrombosis, particularly arterial, in this group of patients. And long-term anticoagulation is recommended for these patients. It's been shown that the vitamin K antagonists are actually the preferred agent for the management of these patients rather than the DOACs. So this is the one category where the VKAs will outperform the DOACs. Very briefly, just to touch on calf vein DVT, the majority of DVTs we've been speaking about are the sort of the proximal DVTs. They're fairly frequent. They most frequently involve the peroneal and the posterior tibial veins. However, there's a more than 10% risk for proximal extension and or pulmonary embolism if untreated. Again, the DOACs have shown to be the preferred agent with extrapolated data. Duration of therapy is usually 3 months. If it's related to malignancy, then one can look to extend that therapy. So we've got a surgeon talking about DVT. So there has to be some role for us in all of this. So what exactly is the role for a surgeon with the management of DVT? So we're really interested in that segment of DVT patients who've got iliofemoral involvement, because it's been clearly shown that there's a very high incidence of post-thrombotic syndrome in patients who've got iliofemoral DVT. And there's been a tendency towards a strategy of early thrombus removal with the aim of reducing the incidence and severity of post-thrombotic syndrome. There's a variety of ways that we can accomplish this, either with catheter-directed thrombolysis or pharmacomechanical methods, with or without the use of adjunctive stenting if there's an underlying stenosis or problem with the vein. The major drawback, particularly with the use of thrombolytic agents, is the risk for bleeding that these patients can encounter. So these are just a few images to show you. If you look at image B and image C, it shows you an occluded femoral vein, as well as A has got the superficial femoral vein. Image D is an intravascular ultrasound that shows you significant compression of the vein. And then if you look at the completion images F, G, and H, you can see that the thrombus has been removed. The flow has been reestablished. And if you look carefully in H, you'll see that a stent has been deployed from the iliac vein into the IVC. This is usually related to the May-Thurner syndrome that occurs with compression of the left common iliac vein by the iliac artery. If you think this is the right, this patient is upside down, they were prone, so left appears right. And the final image is the intravascular ultrasound showing a widely patent iliac vein. So just very briefly, just to touch on the evidence, there were a few trials that were done, and there's clearly benefit in patients in reduction of moderate to severe post-thrombotic syndrome in this category of patients who undergo thrombus extraction as opposed to anticoagulation. However, bleeding is still a problem, and one can see that it's clearly safer to anticoagulate a patient rather than to just offer them surgery. This has subsequently gotten a class 2A recommendation. However, one cannot extrapolate thrombus extraction to the sort of superficial femoral vein, the popliteal, or the calf veins. There's no benefit in this category of patients. So finally, the last thing is, what is the role of compression? It's used to reduce pain, swelling, and counteract the venous hypertension, to ultimately try and improve venous outflow and calf muscle pump function. Below knee stockings are generally well tolerated. Patients tend to complain a lot more about the above knee stockings. These stockings are contraindicated if the patient has got severe underlying peripheral arterial disease or they've got severe congestive heart failure. And there's some evidence that the use of stockings early on may reduce the risk for the development of post-thrombotic syndrome subsequently. So in summary, DVT is a significant health problem. It's associated with short-term mortality and long-term morbidity. Anticoagulation remains the mainstay of therapy, with the DOACs now very much in vogue. And due consideration should be given to appropriate thromboprophylaxis for all at risk, particularly in hospital patients. And the need to extend therapy needs to be tailored to a patient's specific risks with regard to risk for recurrence, risk for bleeding, as well as the preference of the patient. Perhaps I can ask Alison Dendy to go ahead and share her slides with us. And Alison is a specialist who's got an interest in wound care. And we can ask her to share wound care and lymphedema. We can ask her to share some of her experience with us. Over to you, Alison.
Thank you. I hope you can hear me.
Yeah, loud and clear.
Wonderful. Thank you. Okay, so I'm going to go through lymphedema as quick as I can. It's a very big subject. No, it wasn't. Sorry. So the definition of lymphedema is a progressive chronic condition that affects many people, from physically, psychologically, and socially. It's incurable, and it's accumulation of protein-rich fluid. And that protein-rich fluid can organize itself and form large amounts of fibrosis. There's fat deposits in the tissues, and all as a result of the lymphatic system failing. It is an abnormal accumulation of protein-rich fluid, as I said, as a result of a failure of the lymphatic system. So the role of the lymphatic system is a defense mechanism. It's a cleaning system of the body, transporting enzymes, fats, wastes. It's a one-way system. So obviously you've got the circulatory system as a circle, and the lymphatic system as a semicircle, starting in the skin and returning it back into the blood system. It generally circulates 2 to 4 liters, returning back into the system in a 24-hour period. But overall, it actually moves around 24 liters in a day. So obviously, it's involved in waste removal, excess fluid and protein from the tissues, recycles. It's part of the immunity system, and it creates a homeostasis in the extracellular space. So primary lymphedema, there are 2 types. You get primary and secondary. Primary lymphedema, as you see pictures that are here, this is a patient that we did. It's a primary lymphedema. As you can see, there's a lot of lymphuria going on. And eventually, the skin, we get it down through the process of bandaging, etc. And then we did skin removal. So primary lymphedema is a genetic malformation of the lymphatic system. And obviously, it can either be an aplasia or hyperplasia or valvular incompetence. And a good example will be Milroy syndrome, which is obviously a genetically sex-linked dominant trait. So primary lymphedema generally develops into 1 to 6,000 1 in 6,000 people. There are 20 to 30 genes that have been identified, as you can see, like FOXY2 or PASL1. Paracox is before the age of 35, and we've actually found out generally it starts at the age of 17, and they think that it's a hormone-related issue that goes on. Tarda occurs after 35 and generally around the age of 49. Something like Milrow syndrome starts at birth or in the first few years, and it's bilaterally affected. Secondary lymphedema is either malignant or non-malignant. So you get your breast cancers, your prostate, ovarian, cervical, uterine, and then you get your non-malignant, which is your burns, your trauma, and then one that we all are aware of, the lymphostatic elephantiasis from filariasis. And strange enough, very commonly has become a self-mutilation, where they actually are tourniqueting to create a lymphedema. The cause of secondary lymphedema generally is damage to the lymphatic nodes and vessels, surgery, radiation, trauma, malignancy, venous disease, immobility, which is very interesting. We'll go through a little bit later on the glycocalyx layer and how that is affected by immobility. Lymphostatic filariasis, obesity is really big. And of course, a lot of the vascular guys will know about the Gilbert-Weber syndrome. So 40% of breast cancer patients will develop post-mastectomy, lumpectomy, sentinel node biopsy, radiation, will develop lymphedema. And a seroma, which is a very common occurrence post-surgery, 80% of them will develop lymphedema within 2 years. And following melanoma, 17.5% upper limb lymphedema and 59% lower limb. So there are the stages of lymphedema. The pre-stage, stage 1, 2, and 3. The pre-stage we refer to as the latency stage. So the latency stage is where there are actually no clinical signs of swelling. Anyone who has had disruption of the lymphatic vessels or collectors, as they're called, or lymph nodes, is known as a latent lymphedema. Now, these are ones that can present with lymphedema at any time, but at this particular time, there is no visual evidence that lymphedema is present. So they generally will complain of heaviness, aching, warmth, a feeling of fatigue, of fullness, but there is actual no or change of skin color or change of skin texture. Where we get to stage 1, and often it's an infection or heat that can trigger the latent lymphedema to change to a stage 1, and very often infection. And this is where the patient will complain that the limb is swollen at night, but it's gone in the morning, reduced very easily. It's reversible. It's a soft pitting edema. And you can see the triggers that occur. And one very interesting one, they always talk about travel and car travel. And recent studies have shown that it's actually not the change of compression that occurs or the change of altitude that occurs within, for example, flights, but it's actually the fact that they are stationary for a significant period of time. And with their knees flexed, the popliteal area is compressed, and therefore the lymph will increase. There's a lot of tightness, heaviness, decreased ROM, and there's something called a positive pinch test. And this is something that is very useful for a GP to actually identify. And if you take your index and thumb and put it at the base of the big toe or at the base of the second finger, you can lift, in most people, that skin off the base of the tissues below. But in lymphedema, this positive stemmer sign pinch test, the skin cannot be lifted. And that is a fundamental identifying factor for people to identify whether this is a true lymphedema or just an edema. So stage 2 is where the edema becomes rubbery hard, thickened. There's obviously a positive stemmer sign or pinch test, and the chronic pitting is no longer soft. It's heavy, it's indents, and the indentation stays there for a significant period of time. and it is not irreversible. So you can't just lift your limb up at the end of the day and everything is fine. It doesn't go away. So a stage 1 will develop into a stage 2 if the stage 1 is not actually treated yet. Now, stage 3, the elephantiasis, is actually not the size of the limb, and you saw those previous pictures. An elephantiasis is the type of tissue that is developed. Obviously, it's irreversible, and it develops from a stage 2, generally triggered by an infection. They always are in a garment. It is a hard tissue. The tissue is no longer pitting. There are large papillobloma on the skin, and there's a lobular deformation of that skin. Now, the picture that you're seeing right now is actually a filariasis patient. And although it looks like there's only a left leg affected, the right leg is affected as well. And that is a typical, not incredibly huge, as we all think an elephantiasis should be, but it's the type of tissue that you see. Treatment is divided into 2 phases, intensive and recuperative. In the intensive phase, our aim is to get the limb down as small as possible. And then the recuperative phase is to keep it at that size. So obviously it's a manual lymph drainage, which is a gentle technique in which you're able to move the fluid into the areas to get the body to reabsorb it or to excrete it. The bandaging technique, which we'll go through, is a multi-level bandaging technique, and it's there to add pressure on the outside against the musculature to add a pumping effect when moving. So the decongestive exercises are vitally important to do to actually pump the fluid out, and without the bandages are pretty ineffective. Skin care is vital. Being a protein-rich fluid, wounds are very easy to develop. And strange enough, we talk a little bit about the wound. If you do develop a wound, the first option is, take off all the bandages, take off all the garments. Well, what we have decided is that the best option is to actually add the garments or the bandages on, because if you have a wound of 5 centimeters with edema present, if you reduce the edema, the edges of the wound go closer together, and therefore you actually have better wound healing. With fluoroscopy guided MLD, I will talk about this a bit later. It's a new technique that has been devised in which we actually inject ICG into the lymphatic system, and under real time, you're able to see where the blockages are. And what's commonly found is that the scar itself is a major form of blockage, which is why with the fluoroscopy, what is now being shown is that if we can pre-op do a fluoroscopy, find out where your sentinel nodes are, where your main collectors are, and adjust where the surgery is occurring, you can actually prevent a lot of lymphedema forming. And K-tape is obviously something that is used a lot. That's the sports taping, and the aim is to lift the skin up to allow for a suction effect for the lymphatic collectors to function, so that you get the fluid moving from lymphangion to your valvular formation, and that then pushes it open and moves to the next lymphangion. So in the recuperative phase, you teach the patient, with the help hopefully of fluoroscopy, to actually see where they do their own lymph drainage and they become independent of the therapist. That's when garments are fitted and the decongestive exercises are done within garments, and skin care is continued. So the method to contain the swelling is via a variety of bandages. So both Leduc and Casey Smith, both in studies, showed that multi-level bandaging with exercise helps reduce the edema. And the multi-level bandaging is done in a short stretch bandage system. So it's not an ACE bandage. It's a short stretch, which means that it has a high working pressure and a low resting pressure. So you eliminate the need or the possibility of tourniqueting. So it's a layered system. In the low limb, you would use anything between 4, 5, or 6 bandages, depending on the size. You use a padding the padding is there because of the law of Laplace states that if you bandage an uneven area, you'll get uneven pressure. So we make the limb with padding to a cylindrical form so that you're able to actually apply compression through all the areas equally. So how it works, it obviously reduces ultrafiltration, which means that less lymph is actually formed. It enhances the muscle pump, which we've talked about. It prevents the reaccumulation of lymph. It also, with the form of rubbing against the skin, reduces fibrosis, helps with skin changes, and of course with lymphorrhea, that is very common. The most important treatment with lymphorrhea, which is obviously the leaking of the lymph out of the skin, is to apply a compression to it, that which actually physically stops the fluid from leaking out. And then obviously it enhances venous flow, which to increase the wound healing. So you've got various choices of garments. You've got your circular knit, which is generally a venous-related garment. And in lymphedema, the gold standard is to go for a flat knit. Now, a flat knit is knitted, as it says, in a flat fabric and then sealed at the back with a stitched at the back. It is very important the flat knit garments are there because they actually bridge over the unequal folds in the skin and then don't cause a tourniquet effect, which the circular garments can. So you can either get ready to wear a flat knit or custom-made flat knits. And another interesting thing is night garments, which is a very nice way of actually improving the limb at night. So very often in your stage 3s, they are in a flat knit garment during the day and a night garment at night. And something recent that has come up is wraps. And you'll see a picture on the screen of a wrap, which is the patient is much easier to apply on their own. They're taught how to do it. There are markings on the wrap so that you know how much compression you're putting on. And for the elderly patients, it's far more comfortable, or patients that are not as mobile. The compression classes in upper limb go class 1, 2, and class 2 forte. And you can see the millimeters mercury, obviously being very cognizant of your ABPI, making sure that you are not contradicting what that actually is. In your low limb, you go in class 1 right up to class 4 super, which is 60 to 90 millimeters of mercury. Now, that's a huge amount of compression to put on a limb and done very carefully with correct assessment whether it works. So talking about the glycocalyx layer, history has told us that 78% of interstitial fluid drains into the venous system and only the balance 20 to 30% enters the lymphatic system and becomes lymph. We now know with the MRIs that go on and all the technology that has developed that we have something called a glycocalyx layer. They are hair-like structures in the capillary wall, which move and maintain the health with shearing forces. And this layer prevents the limb from actually entering the vein. So all fluid that is produced goes into the lymphatic system as a protein-rich substance, fluid, and is 100% lymph. So nothing goes into the venous system. The glycocalyx layer is very interesting. It's broken down by alcohol injury and lack of mobility. So our patients that are sitting in bed for an extended period of time and start developing swollen limbs, it's often as a result of the glycocalyx layer breaking down itself and then allowing leaking of fluid. So obviously you've got your atherosclerosis, your fatty deposits, they also damage the glycocalyx layer. And this damage and thinning of the glycocalyx layer, it becomes porous and results in edema. So talking about lymphophoroscopy, and this is my pet love in life, lymphatic mapping was devised initially in Belgium, and it's now extending quite heavily across the world, and is now available in South Africa. It's performed using a photodynamic eye, which is a near-infrared imaging camera. And what actually happens is they inject ICG, indocyanide green monosodium salt, into very superficial into the lymphatic system. And using the photodynamic eye, you're able to watch the moving of the lymphatics and the fluid within the lymphatics in real time. Now, obviously, ICG, we all know, was used initially as for cardiac output, etc. And we now, and also with sentinel node visualization in oncology. But the ICG that is used for lymphatic mapping is 1/100th of the dose that they use in those cases. And of course, it's obviously an unregistered medicine in terms of Section 21. So why would we use fluoroscopy? It's very beneficial to identify the lymphatic patient, and it improves the outcome of their treatment. For example, if you are treating a patient with a complicated lymphedema, you map that patient, you can find out where the blockages are, but more importantly, where it drains to. So you find the exact pathway for each individual patient and therefore improves its treatment plan. And studies that are actually going on at the moment are to identify patients pre-op. For example, let's take your breast cancer, identify the sentinel node, identify the lymphatic collectors draining to that sentinel node, and identify that patient's individual drainage pathway. Then with careful techniques and surgery, the actual scar and where you go into the patient to remove that sentinel node and do surgery, you can avoid the main pathways and cutting those pathways. So it's a very useful way to allow the patient to have a precise self-help FGMLD drainage pathway so that it speeds up the treatment and becomes a lot more beneficial. So on the picture on the left-hand side is the normal look of a healthy lymphatic system in the foot. And you can see the 2 injection sites, which are distal. And then if you look, the pathways go up. Now, there are many, many pathways in the foot. But like anything, the body chooses the easiest path to go. So you generally find a pattern very similar to this in a lot of functioning feet. And if you look carefully, you'll see the gaps in those pathways, which you've got your lymphangion, then you've got your valvular formation, lymphangion, and so it goes up into the body. So when you inject a patient like this, the movement of that fluid is incredibly quick. So it moves out and it absorbs through the body, and you watch it go the whole way up the leg. It either goes popliteal or anterior thigh or lateral into the inguinal area if it's in the foot, and is disposed of sufficiently. In the middle picture, you'll see an unhappy or unhealthy lymphatic system, where what has happened there, you've injected the fluid, it has nowhere to go, so it pushes up into the surface, and that is known as dermal backflow. So the fluid cannot actually get out, so it pushes back down into the feet and into the toes. In the path on the right-hand side, you'll see that the fluid has gone up. You can see the blockage, and then that little squiggly line, which is moving to the right-hand side, is what you call a diversion pathway. So the lymphatic system is very clever. It finds its own way out. So with the use of that diversion pathway, you can then teach the patient to access where that fluid is going. That diversion pathway will then go and connect onto another lymphatic and then drain up. So here's a patient that we have mapped. As you can see, it's a right leg lymphedema. And you see the foot is not involved. So you'll see lovely collectors and a lot of drainage pathways going up. But you'll see that at just above the ankle, it blocks, and that is where her damage occurred. So all the dots that you're seeing going up her leg is what we call stardust. And that is where the valves are actually lit up by the ICG, but it's not draining. Well, luckily with her, as you come above the knee, you will see that she hits a pathway which goes from medial to lateral. You'll see the line going up, and if you go to the next pathway, you'll see that goes up the side of your leg, and then actually doesn't drain inguinally. It drains to the sacral area. So with this knowledge, she is able to then drain her own body that is most effective for that leg. So it takes all that effort away, where you're just pumping on areas that aren't functional and going onto the lymphatic collectors that are working in the correct direction. Okay, thank you.
Okay, thank you very much, Alison. It's always striking whenever I listen to your talks about how passionate you are about this. And, I think there's a lot of patients that will benefit from more dedicated therapy in this field. So thank you very much for your time. Once again, if you do have any questions, you're more than welcome to put it in the chat box. We're running a bit short of time. Our next speaker is Dr. Zaki Sheikh. He's a vascular surgeon in the Durban area. Zaki is one of our foremost, I would say, venous specialists. He's on the Venous Society of South Africa, and he's got quite a few tricks when it comes to venous pathology. He's going to give us a talk on the contemporary management of varicose veins. Zaki, over to you.
Good evening, everyone, and thanks, Moin, for that introduction. Right. Okay, so Moin, can you just tell me, can you see the slides? Am I clear?
No, we're seeing your video right now. We're not seeing your slides, Zaki.
Video.
Yeah, looking quite smart today.
Okay, well, let me just see what's happening here. Can you see the yeah, how's that?
It's starting to load, I think. Yeah, here we go. We can see your slides.
Right. All right. So, okay, so good evening, everyone. So I'm gonna briefly talk to you about the modern approach to varicose vein treatment. Again, it's a very, very comprehensive topic, but I'm gonna keep it a bit light. Since you've had quite a few heavy, comprehensive talks, so this is gonna be mostly visual and practical. So, the oldest known depiction of varicose veins it dates to about 340 BC in an Athenian temple, where a fake leg suffered from varicose veins was created by the Greek official Lysiades and dedicated to Ammonos, the Athenian hero associated with healing. I think more so, this illustrates that this problem has been an age-old, problematic area in medicine, and treatment has ranged, from simple compression to cautery to ligation to stripping, over the years, and we still continue to try to find newer ways to treat this. And I found myself reading George Orwell's 1984 in light of the contemporary politics, and it kind of looks like we are entering some kind of a totalitarian society. And it's funny because the lead protagonist in this book, those of you who have read it, Winston, has his varicose ulcer, which troubles him throughout. And in analysis of his character and his ulcer actually has a theme. It represents the depression and the physical toll of living in a totalitarian regime, and I found that quite interesting. So I think the important thing is recognizing problematic varicose veins. We would think of varicose veins as being, just a cosmetic issue, and most people just think of it as cosmetic issue, and the problems that we have with funders are they also see cosmetic, and there's nothing wrong with treating a cosmetic problem as well, but there's a big, huge box, of symptomatic varicose veins, and that again can be largely divided into those with skin changes and those without skin changes. Without skin changes, largely they would have edema, may present with a bleeding varicosity, which is quite graphic, and they may have restless legs, pruritus and local discomfort. And then you have those patients who present with eczema and ulcer formation. And there are classifications like the SEEP classification, which we commonly use, in classification. So this largely presents how varicose veins would present, either symptomatic, and asymptomatic or symptomatic, and if symptomatic, with or without skin changes. So this is the basic vein anatomy diagram, just showing the saphenous vein that joins up with the common femoral vein. And then behind the knee downwards is the short saphenous veins. So this largely be the common veins that we would treat. These are common truncal veins. Again, close to the great saphenous vein, where it goes up to the groin, you would see what's called the anterior tributary and posterior medial tributary. The anterior tributary, or the anterior accessory saphenous vein, has been given its own name now known anterior saphenous vein. So it's widely regarded as the third truncal vein, of superficial veins, and purely because of how common it is and well-evolved treatment strategies to treat that. The picture on the right just shows a very tortuous great saphenous vein that's refluxing below the knee. This is a picture again showing the anterior saphenous vein. And you can see this is those of you who would see patients with varicose veins would notice this tortuous tributary going across the anterior aspect of the line across the knee. And that usually links up directly, with a common trunk with the great saphenous vein going into the common femoral vein. Now, it's important, this is a picture of one of the patients I've treated recently. And as you can see here, there's skin changes, the thickening of darkened area at this point here where it meets normal skin. This area is called lipodermatosclerosis, and represents fibrosis. And the pigmentation represents hemosiderin deposition. And we can see there's been some eczema and this ulcer formation laterally and medially. Typically, it will occur medially in the gates region, but it also quite often occurs laterally in line with the reflecting tributary. Unfortunately, this patient was managed with the topical fusidin and oral antibiotics repeatedly for almost a year before seeking venous treatment. And these are quite profound varicose veins, that we've, in terms of size, again, we can see this is mostly anterior accessory and posterior accessory, more of that here. And then some of them are absolutely difficult to even find the original truncal vein because large side tributaries, large tributaries extending below the knee. In this patient, you can see the extensive skin changes, the hyperpigmentation due to the hemosiderin deposition. And then there's foot varicose veins, or corona phlebectatica, that look like a crown, basically. And that's just indicating a marker of severity of varicose veins. So the next thing that you would do after seeing that is that you would want to obtain a duplex ultrasound of the superficial and deep veins. Varicose veins, the diagram, the schematic on the right just shows what a normal vein should be on the left, which is veins being stopped by competent valves. Now, flow through a vein is not like through an artery. An artery would have the laminar flow, and flow through veins follows columns. It basically moves from column to column, from valve to valve, and that is stimulated by the calf pump. So when you have an incompetent vein or a refluxing vein, you'd find that the net effect is fluid not leaving the foot, or ambulatory venous hypertension, and this results in all the skin changes and the dilating varicose veins. On the left, of what we would find in a refluxing vein. So on the left, you would see normal flow of venous blood, and this is augmented by calf, by squeezing the calf, and then subsequently the reflux, you'd see it on the other side of the line, just flowing in the opposite direction to what normal venous flow should be. And a reflux time of more than 0.5 seconds is considered to be significant. And after assessment, a clinical assessment, and a duplex vein ultrasound, you would get something like this. This is one of my patients' vein maps where we work out, where we map on which areas that are incompetent. So on the right, you can see it represents the right thigh anteriorly, the right lower leg anteriorly, and the right leg posteriorly. here the patient's got great saphenous vein reflux into a tributary, and behind his knee he's got short saphenous vein into multiple tributaries. On the left lower limb, there's a saphenous vein reflux into tributaries medially, but on the left behind his knee, there's a very large diameter short saphenous vein reflux. And based on this, we formulate treatment strategies. So before talking about modern vein treatment, I think modern comprehensive assessment is important. So recognizing what is chronic venous insufficiency earlier on. So if a patient with lower limb symptoms with associated skin changes and ulcer formation, I think comprehensive assessment of the circulation is paramount. Arteries and vein, before thinking of anything else, or at least think about it. If you're not going to investigate immediately. Then obtaining a comprehensive venous study of both lower limbs is important. Timely referral to a vascular surgeon for further assessment and treatment definitely prevent long-term complications. And if there are associated wounds, these patients would require 4-layer compression treatment for ulcer healing. And this needs to be complementary to treatment of the underlying chronic venous insufficiency. So treatment strategies. So from what I've described so far, the superficial veins can either be truncal or tributaries and with perforases. Truncal veins are the great saphenous, the anterior saphenous, and the short saphenous veins. And there are strategies for treating each of them. So for truncal veins, based on vein diameter, depth, and tortuosity, if it's more than 5 centimeters from the surface of the skin, follows a relatively straight course, less than 12 to 15 millimeters in diameter, then these patients would be deemed to be endo-suitable, right? And by endo-suitable, we mean endothermal venous ablation, either with laser or radiofrequency ablation, over high ligation and stripping. So we'll talk about that now. If the veins are less than 0.5 centimeters from the skin surface and follow a tortuous course with a very large trunk diameter, then these are really endo-unsuitable, and these patients would require additional ligation and stripping plus phlebectomy over the endo techniques. And importantly, if there's no endo expertise or equipment available, then even those patients who are deemed to be endo-suitable should be offered high ligation and stripping plus minus phlebectomies. So looking at some evidence from the American Venous Forum in 2024, there's a very strong recommendation, which is grade 1, and evidence B involving a randomized trial, basically recommending that for all patients who are symptomatic with varicose veins and axial reflux in the great saphenous vein, who need intervention, they would recommend endovenous therapy over high ligation and stripping. Right, so both are equivalent and are quite good, in terms of treating the symptoms. But obviously, with endovenous treatment, you have the benefit of not having wounds, not requiring a hospital stay with general anesthesia. But a very important point in that guideline later on in 4.1.4, if technology or expertise in endovenous ablation is not available, then it's still recommended that patients undergo high ligation and stripping of the great saphenous vein. And this should not be managed non-operatively if endovenous techniques are not available. So this is a little short video showing how this is performed. With ultrasound guidance, a sheath, the great saphenous vein at the left of the knee accessed, and the sheath is placed, and a radiofrequency or laser catheter of your choice is placed about 3 centimeters from the saphenofemoral junction. Okay, that video is not showing it 3 centimeters from the saphenofemoral junction, but it should be at least 3 centimeters away from there to prevent heat-induced thrombosis. And tumescent anesthesia represented by that reddish fluid, and that's a mixture of local anesthesia, bicarbonate, and adrenaline is injected with the ultrasound guidance around the great saphenous vein containing the catheter. And this catheter is, you can see it's got a long segment of heating capability similar to the metro catheter, the closure fast catheters that we use. So it will ablate the vein in segments. And all of this is done under ultrasound guidance Right. And yeah, so that's endovenous treatment. There are some non-heat-induced treatments. There's non-thermal endovenous techniques, but we won't go too much into that. The evidence for that is not as strong as for endovenous endothermal treatment. Then there's the issue of tributaries. Now, tributaries are always a branch emanate, from these truncal varicose veins. And there's strong level of evidence that these should be managed with ambulatory phlebotomy and ultrasound-guided foam sclerotherapy or both, right? And so sclerotherapy is least invasive, but associated with a higher recurrence. Phlebectomies give a better cosmetic result, but does require some local anesthesia. So usually it's a combination of both that give good outcomes. So this is right. This is the sclerosant that we usually use in SA, which is Sotradecol or Fibrovain. We constituted via this is 3%, but usually we use much diluted versions, 1.5%, and by forming foam via the modified Tasari technique, we inject this into these tributaries. There's just a video showing how it's performed. And I would love to say those veins disappear just like that, but it doesn't. But that's in principle is what happens. And yeah, so the previous one showed you sclerotherapy. This is just a short video of ambulatory phlebotomies with local anesthesia. You would access large subdermal veins, and there is a technique in terms of access it using phlebectomy hooks, and then we would divide the vein, and then proximally and distally would apply traction and move as much as possible. So these techniques can be done quite nicely, in an outpatient office-based setting. And on the left, there's just showing some of the segments that are removed. So what are the contraindication? What are the contraindications to endothermal techniques? So as much as we would like to use all of these modern techniques, if the saphenous trunk is situated very close to the skin, less than 5 millimeters, is very tortuous and unable to accommodate the device, this intraluminal thrombus, and if the saphenous trunks are very large, more than 12 to 5 millimeters, then it is largely recommended to do highlightation and stripping, as there's a high degree of failure or complications that would come from the endothermal techniques. So modern highligation stripping is an improvement on the original highligation and stripping, where we use some of the modern techniques like ultrasound and fluorescent anesthesia to assist with stripping. And this actually allows these procedures to be done, as a day procedure, local anesthesia in some cases. The benefits of using tumescent anesthesia is the benefit of tunnel hemostasis that we achieve with excellent post-op analgesia. And there's good evidence, and recommendations from the guidelines that if it's performed with modern highligation and stripping performed after detailed mapping under local or tumescent anesthesia, remains a good option with similar 5-year results to endovenous thermal ablation. So here's there's a little video of a case that I performed with the short saphenous vein. The saphenopopliteal ligation and stripping of a short segment of a large short saphenous vein. This is a video showing the tumescent anesthesia technique with a needle, injecting the local anesthetic solution around the short saphenous vein containing the Codman stripper. And the purpose of this is to move the sural away from the vein. So Alban has really made a lot of these techniques possible. And once we've obtained a good tumescent anesthesia, the vein is stripped out, and it usually comes out quite easily because of the solution. And here's the vein that's intact after stripping. So in conclusion, there's no one size that fits approach. There's not a one-size-that-fits-all approach to varicose vein intervention. We've got techniques, multiple techniques for ambulatory venous treatment, which involves endovenous ablation of truncal veins. You can use laser or RFA or the non-thermal techniques. There's ambulatory phlebectomy. There's sclerotherapy. Open surgery is still relevant, but in a smaller set of patients, maybe part of a hybrid procedure, maybe indicated due to anatomical reasons. It may be necessary due to unavailability of expertise and technology. And modern open surgery has very good outcomes. But I think the most important thing is recognizing chronic insufficiency and referring early for treatment is key to better patient outcomes. Thank you.
Zaki, thank you very much. Once again, I'll invite the people on the platform to post questions if they are interested. I'm going to share the screen. I'm not going to keep you too long. I know you've all sat through this meeting. Zaki, can you just tell me if my slides are showing?
Yes, they are.
Okay, so in conclusion of this evening's meeting, I'm just going to give a few points. I'm not going to take too long about how we can expand vascular care, particularly in the South African public service. Now, just for statistics purposes, we have a population of around 63 million people, and we have approximately 70 vascular surgeons that are certified in the country. In 2021, there was an article published by the VIDS group, and they actually counted that there was only 18 vascular surgeons in the public service. And this is now 5 years later, and it seems that number hasn't actually improved or increased despite a new influx of vascular surgeons. So when you put that to numbers, in the public service, we only have 0.3 vascular surgeons per million population. That's one vascular surgeon for 3 million people. Whereas in the private sector, we have 5 vascular surgeons per million population. And that's a very, very, very stark and major difference. Now, we know that in the public health landscape, the majority of patients are uninsured. We have a large population that are not in urban metropolitan areas. But the majority of vascular surgeons, particularly in the public service, are in central academic hospitals. There's referral pathway delays from the periphery up to dedicated units. And unfortunately, we still have too many junior doctors that are alone on the front line without significant experience to make decision-making. And of course, there's underfunding in state facilities. And this is where vascular surgery is actually the perfect storm, because procedures in vascular surgery generally are required on an urgent or emergent basis. I think if you ask any vascular surgery vascular surgeon, public or private, how long is their waiting list? And unless it's varicose veins, there isn't really a waiting list because patients need to be operated on a very, very urgent basis. Most of the vascular patients require repeat procedures. That's particularly important in dialysis access procedures and for limb revascularization. And then, of course, we've moved now to the modern techniques of minimally invasive endovascular or hybrid techniques. And that generally requires costly equipment and consumables like cath labs or dedicated C-arms, implants like stents and balloons. And to run a good unit, you actually need a dedicated team of 24-hour availability, which includes radiographers, anesthetists, assistants, theater staff, and reps. And as you can see, that's why I say it's the perfect storm, because to get this type of setup in the public service is actually very, very difficult, even in the academic centers. Now, the burden of vascular disease in South Africa is very, very high, particularly with atherosclerotic disease. And one of our colleagues spoke earlier about diabetes-related vascular problems or foot problems. And particularly, we have a very high amputation rate in the public service, largely due to delayed presentation, delayed referrals, and cultural ideologies of our population not wanting to be amputated. We have a very high burden of venous disease, as Dr. Sheikh was just talking about now. And this is really a quality of life disease. It's not really life or limb threatening. And it's in the public service, something that's quality of life is generally not prioritized, and there's very little access to quality care. However, things like venous ulcerations really is a very costly condition for patients, not just from the social aspect, but also from the economical aspect. Even though in South Africa we have very little access to dialysis in the public service, there are units around the country that offer dialysis. But without dedicated vascular units, it means that access to dialysis, access surgery is even more difficult. And as I mentioned in the previous slide, many patients require repeat procedures. Aneurysmal disease is probably not the major disease that we find in the country, but it is present. Now, why is it important to prevent amputations? There's a linear association between the lack of vascular services and the high rate of amputations. And the important part is that on average, the mortality risk after a major amputation, particularly a below or above knee amputation, is 50% in 2 years and up to about 70% in about 5 years. So if we can prevent an amputation, we could in fact save a life and in the long term save money, because these people can still be economically active, they can still contribute to society, and there isn't really in the public service a very good availability of prosthetic limbs because of the cost. Now, I'm just going to tell you quickly about the approach that we are using in Rustenburg, and the provincial hospital in the Bojanala Rustenburg area is called Joshua Kanatabani Hospital. It's a multi-speciality facility, but with a lack of resources, historic lack of resources. The hospital services a population of close to 2 million people, and if you've been following the media lately, you know that the Northwest is one of the provinces where the majority of the population is actually unemployed. So of that 2 million people, the vast majority are dependent on the services provided at JSC Hospital. Previously, vascular patients were transferred to academic centers for further treatment. So since I joined the unit, the hospital in 2021, there's been a setup of public-private partnerships for cardiovascular care. We've got 2 cardiologists and myself as a vascular surgeon. And we utilize the local private facilities to provide subspecialty care. This allows us to provide care locally for our patients, avoiding transfer to academic centers and avoiding patients being just part of the queue at the academic center. It's also become an excellent training platform for junior doctors keen on a surgical career, but also it's also been a platform where we've launched some of the recently qualified vascular surgeons in giving them baseline vascular surgical exposure and experience. So what have we done in the last 5 years? We've done about 200 vascular cases, but this is just the tip of the iceberg because the demand for the service outstrips the capacity at which we can provide it. It really is in a lot of cases when you think of the amount of patients that require vascular services. Cases that require specialized facilities are done at our local private hospitals just for the utilization of the hybrid theater and often overnight ICU stay. And over the 5 years, we've actually progressed now where most of our open cases are done in-house without transferring them out. Open aortic and bypass surgery is now routine at JSC Hospital. And over time, staff attitudes have become positive towards this, even for 4 to 5 hour procedures. And amongst the staff, whether it's the doctor complement or the nursing complement, there's always the sense of punching above our weight for the size of our hospital and the facilities available. We're also now offering varicose vein surgery for symptomatic patients with chronic venous disease, particularly those with hyperpigmentation and leg ulcers that are severely symptomatic. And I would argue that we are probably providing more varicose vein surgery than some of the academic centers who just don't have the time to provide intervention for a condition that, as I said, is a quality of life issue. So what has been the result is that the output that we've done shows that the demand is real. We have a strong hospital management that has a long-term vision and plan for the hospital, and with showing our results, they've managed to secure funding, and there's active plans in place for state-of-the-art cardiovascular facility in the hospital. This will benefit patients, it will benefit training, it will reduce costs, it will save lives and limbs, and the benefits just go on and on and on for what the facility can provide us. So in conclusion, the wheel does not need to be reinvented. Provincial hospitals around the country need to recruit subspecialists. And initially, they need to provide a public-private platform to allow services to be provided to assess the demand. And definitely once the services are there, the patients and the demand will follow. And over time, the investment will be paid off. Now, why did we show all of this? To showcase what we're doing here is so that if there's any doctors, not necessarily vascular surgeons, but if there's any hospital administrators that are on the call, if there are any heads of departments, if there are any even medical officers who realize that there's a demand in the outpatient department for vascular services, to take this type of an idea to your hospital management, to your provincial health department, and say, we need to recruit subspecialists. There is a demand. There is a plan. It has worked elsewhere. Yes, it might be initially costly to use private services, but over time, once you develop your own system and your own service, your own facility, those costs will come down astronomically, and more services will be provided for more patients. And it's undeniable in the vascular surgery patients that by saving limbs, we ultimately save lives by preventing mortality, and this undoubtedly saves money. I thank you for attention. I'm just going to check if there's any questions in the box. I don't see any further questions in the chat box. From our platform, I'd like to thank all of you. I just want to see if there's, we're out of time, but if there are any final comments from any of the platform of the presenters, if you want to have any questions to the other talks or any other comments, please. We got about 2 minutes maybe, and then we'll close the call. I see there's one question in the chat box which we can take so long. One of the delegates says, I work at a tertiary facility and was fortunate enough to work as a physio at the vascular clinic. It was fulfilling. Does part of your team include a limb-trained physio? So at the moment, not, because we really at this point dealing with life and limb-threatening procedures. We don't have that. However, it's a good suggestion to look into because the demand for lymphatic services is there, and it's usually, these patients are not well treated. So that's a good suggestion, and we will take that forward. Thank you very much for that comment. Anything else? Dr. Sheikh, Dr. Dokrat, Alison, Dr. Khopani, any other comments before we close? Zaki, go ahead.
Thanks, Moin, for quite an impressive presentation about what you guys are doing up in Rustenburg. I must congratulate you and the team. It was a lesson for all of us to take back home. But also, I just wanted to make a final comment regarding vascular pathology. It's been a comprehensive presentations on everything from diabetes to DVT and varicose veins. I think the most important thing is to have a list of most important vascular conditions to always think about. If you're not thinking about it, you're not going to look for it. Because we always find that most patients would, sometimes in a busy outpatient may just, default to leg pain, just give them simple analgesia, or, maybe get an X-ray and see an orthopod in the morning. Or if you've got an ulcer on the limb, then just treat it with topical antibiotics or whatever, and just dismiss it. Something that doesn't, if it doesn't look too severe, then it can't be severe. I think more importantly, you have to consider things like acute limb ischemia, chronic critical limb ischemia, symptomatic varicose veins, deep vein thrombosis. Keep that at the top of your head. Whenever you see limb symptoms in a lower limb, especially if they come into a casualty type of setting.
Thank you for that, Zaki. Just one question for you that I have. Patients with recurrent cellulitis and incompetent, not necessarily varicose veins, but incompetent saphenous trunks. Do you think there's a benefit in offering those patients endovenous ablation?
If there's recurrent varicose vein and they're getting cellulitis because they're pruritic, and that's the reason why they're getting cellulitis is because of recurrent pruritus, and they're scratching themselves, so definitely the reflux should be treated. Because prior to presenting, with the established skin changes, there are symptoms, discomfort, pruritus, so definitely, consider it a symptom, of varicose veins or recurrent varicose veins, and to treat it as such.
Thanks, Zaki. I see Ahmed Esop Patel put my name there, but no question. I think in the interest of time, we've exceeded our allocated time. I would like to thank our speakers again. Thank you so much for offering your time to the Vascular Society and to the program for this outreach programs. We really appreciate your time, especially Alison, Dr. Dokra, Dr. Khopane, Dr. Sheikh, as well as Dr. Goga. He had to leave. Thank you, everybody. And we hope that you would all join the next meeting. Those dates will come out in due course. We have a meeting, I think, every quarter. Some of them are live in person, some of them are online. Just keep a lookout at your local medical groups and things like that. There will be invitations sent out, and you're more than welcome to join those meetings. Thank you very much. And Tanya, I think we can close the meeting.